in general, like one of my criticisms of just like the PT world in general with the ACLs is how high re-injury rates are coming out of PT for whatever reason and stuff like that. And so I'm just curious from your perspective, if you have a thought process of what are some of the contributing factors to that, like in terms of people trying to get back to full sport and either not making it back to the level they were at before, getting re-injured, or entering the opposite side shortly thereafter.
Yeah, I'm smiling. So people who are listening to this, I'm literally smiling right now because I get this all the time and I love talking about it. So with anything that we have to do in injury or even in life, there's always modifiable factors and there's always non-modifiable factors. So there's things that you could do and you can change, and there's things that you can't. So there's a lot of factors that go into this. But talking about the modifiable factors, so things that we can actually do, is that as physical therapists, as a community as a whole, we suck at rehabbing ACL patients. We just stink. We're not good at it. And the reason for that is because we underload so much. Like, we don't load them enough. We don't challenge people enough. And even the people who want to get back to recreational stuff. So just like, oh, I'm going to go on a hike, or I want to play with my children, or I want to do the simple day-to-day things in life. You still need to load them. You still need to do things to make sure that their quad is strong and ready to go. And that starts from before surgery. So that starts from the prehab to after surgery, to making sure that in the beginning, you're doing the right things to activate the quads, to the mid phases, being able to load them and push them as much as possible. Obviously to certain limits, because if you push them too much, they start to swell up and they start to get angry and he gets pissed off, like those kinds of things. But I just think that's one of the biggest things that the rehab community needs to get better at. And that's why you see a lot of this like remote coaching that complements in-person physical therapy, or someone finishes like about a physical therapy in person and then they're like, okay, but what now? Like, I'm 6 months out, but I still feel like I don't even know how to run properly and don't know mechanics of certain things, and I'm not strong enough. And then they seek out other options. People like you, people like me, and they start training with them. There's so many different factors that I could talk about, like why injury rates are so high. And there's so many rabbit holes that I can go into, but I think that's the thing that we can change the most. Because if we get better at our rehab, of course, that's not like completely preventing every ACL injury from happening again. Some people just have bad luck because they do the wrong thing at the wrong time. But I think that's just a huge thing that all physical therapists need to understand.
Yeah, that makes a lot of sense. And like you said, like guys like you and me are in that exact like what now space for athletes, because that's the biggest thing that I see. And I think the insurance model gets in the way a lot of people, but yeah, there's lots of things that like you said, I think that loading piece is probably the thing that I would agree with the most, or one of the things that I think about as well that seems like is missing from there. With that specifically, when it comes to loading, are there any ways that you are interested in loading that's maybe a little bit more different from traditional protocols? Like for me, I tend to be critical of what I see as like an over reliance on like the exercise selection side of things, and a lot of stuff that's like box squats, single leg squats, like leg press, things that in my opinion, I see a lot of athletes learn to like cheat and compensate with like more hip dominant patterns rather than more knee dominant patterns. And so I'll get a lot of athletes who progressed a lot in those exercises and they're like, I'm strong. And then we change the exercise selection and all of a sudden they're not quite as far along as they thought they were. Is that just coming down to the intensity of loading, like you meant, like just not pushing that very far, the exercise selection, like all of the above? What's your thoughts on that?
You are speaking my language, Zach. This is literally my language. The biggest thing with this is that people don't understand that squats, leg press, step downs are not good quad exercises. I'll repeat that again. Squats, leg presses, step downs, the things that you were saying before are not good, like knee dominant quad exercises. The reason for that is because the body is very, very smart. And when a body part is injured or doesn't want to work, then the body will compensate in many different ways, using a hip dominant pattern, using the hips, the glutes, the calves, other muscles in the body in order to make sure to complete the task, whatever task that you give it. So what we need to do is, as physical therapists, number one, assess isolated quad exercises. I shouldn't say isolate because you can't completely isolate a muscle. I would say emphasize, like high emphasis of the quad or quad dominant things. And then I said assess. And then number 2, be able to understand what isolated quad exercises are. So if you do those 2 things, then you'll be able to move forward. So we need to be better at assessing quad strength. And in order to do that, there's many different ways to do it. So with my remote clients,